Good afternoon, everyone. My name is Leah Brandis from Comagine Health. I'd like to welcome you to our half-hour Hot Topic series. These webinars are designed to support your efforts and provide you great ideas for caring for your residents in a 30-minute time frame. To accommodate your busy schedules and brought to you by the Comagine team from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. I'd like to say a special thank you for joining us in the midst of this incredibly stressful time. We are here to support you, and we will be recording and posting the session for those of your colleagues who are unable to attend today. A few housekeeping item details before we start. Please let us know who is on the webinar today by entering your name and facility in chat, as well as the names of any folks joining you so that we have an accurate head count of participants. Your cameras and microphones are muted. If you would like to ask a question, please enter it in the chat and we'll facilitate a question and answer session at the end of the presentation. Please make sure you're chatting to all panelists and attendees. We're excited about today's presenter. Janet Holboke has worked as an older adult behavioral health specialist for the Greater Oregon Behavioral Health, or GOBI, since May of 2015. She provides complex case consultation training through GOBI's rural and frontier communities. Ms. Holboke also serves as a faculty member for the Behavioral Health and Nursing Facilities ECHO and is a certified positive approach to care trainer. Previously, she served as the Enhanced Care Series coordinator for the Office of Mental Health and Addiction Services, now part of OHA. I will now turn things over to Janet Holboke. Let's do a quick audio test with the group. Janet, can you say hello to everyone?
Hello, everyone.
Can you chat in if you can hear her? All right, Janet, you may get started.
Thank you so much, Leah, for inviting me to talk to just this fabulous group. And I thank you all for your heroic efforts during this time. Next slide. The objectives of this training is really to help you get started in assessing what is a behavioral health emergency and what's not, how to respond to those behavioral health emergencies by building sort of a crisis plan beforehand, and also how to enlist community supports as you go about obtaining the most appropriate treatment for your residents in the facility. Next slide. You know, the hard thing is that nursing facilities are expected to provide for all the needs of your residents, and that certainly includes behavioral health needs. And the challenge is that often we're not trained on how to really work with a resident who is really exhibiting urgent behavioral health needs. You know, so when we're confronted with a resident who may be making suicidal threats or statements, or maybe somebody who we know has bipolar illness, but suddenly they're looking more manic, or someone with schizophrenia is more delusional than they used to be, you know, we see a resident in crisis, we become pretty panicky about how we're supposed to deal with that because we don't really know. And so our cortisol gets triggered. Cortisol is sort of that hormone in your brain that turns you into fight, flight, or freeze mode. And so, you know, our thinking brain sort of goes offline and our immediate response is, hey, call 911. So, you know, what really is a behavioral health emergency and worthy of a call to 911? Well, the way that most community mental health programs describe a mental health emergency, as well as judges who make determinations around civil commitment and people who work with that frequently, is that they look at it as a behavioral health emergency as something where somebody is at immediate risk of death or harm to themselves or others. And that really includes, you know, them expressing the intent to harm themselves or others, as well as the access to me. So, you know, I'm going to hang myself with a call cord, and I've got the call cord right here. But the assessment goes further. Do they have the capability to really follow through with the intent that they're expressing? And I think especially for nursing facilities, this is really salient. So, you know, I have the call cord. I intend to hang myself with a call cord, but I don't have the strength to hold on to it. And if I do, it's going to pull out of the wall. So one of the things to look at in terms of what's an immediate risk of harm. And the other thing is to think about a resident's history and whether or not they've had previous suicide attempts or previous acute behavioral health symptoms that's necessitated hospitalization, because that's certainly going to factor into any assessment about emergent need. Another thing that can look like a behavioral health emergency, but it may in fact be a medical emergency, is a sudden change in thinking or behavior, like a waxing and waning of attention, asleep one moment, agitated the next, which, as you all know, can indicate delirium, which could be an emergent medical situation, or a sudden neurological event, such as a stroke. Or rarely in older adults, but at times occurring among younger adults, is an acute psychotic episode where suddenly somebody becomes pretty paranoid, expressing a lot of paranoid thoughts, may be suddenly delusional or have other kind of symptoms that are a significant change. And that's also an emergent mental health situation. I know that for a lot of facilities, one of the behaviors that occur frequently that feels pretty crisis-like is when there is a person with dementia who is aggressive and is a threat to staff, or maybe has actually hurt staff or has hurt other residents, or is at risk of hurting other residents. And that certainly can be an emergent situation. There are specific ways to work with those individuals. However, this today, we're talking about specifically behavioral health emergencies in people without dementia. Okay, next slide. So as we're talking further, I'd like to sort of keep in mind a resident that I saw consulted on a couple of years ago, Wayne. He's not his real name, obviously. He's a male in his 50s. He was admitted about 7 years ago in the nursing facility. He had had a really significant stroke that left him with dense hemiplegia. He's got other multiple complicated medical conditions. And, you know, he has had angry outbursts at baseline. And so what happened is that one evening he was left on his commode chair for what seemed to him to be a very, very long period of time. Staff members came, a CNA came in to take him off of the commode chair, and he was really angry at that point. He yelled at her, he threw a water pitcher at her, he toppled over his tray table, which was sort of unusual for him to be that physically aggressive. And then he said, you know, that's it, I've had it, I hate this place, I hate myself, I hate living here, I'm gonna hang myself with a trapeze bar. And so the CNA, as you can imagine in that situation, just sort of became panicky, left the room, found the charge nurse, and together they decided that they should call 911 and get Wayne out of there. The paramedics arrived. They took Wayne into the emergency room. Once he arrived in the emergency room, he was immediately regretful, felt badly that he had gone too far, said he wasn't really going to hurt himself, that he was just really mad. The emergency department was not happy that they had had a resident that was transported to them for, you know, in their view, no real reason, and sent him back to the facility with some admonishments. And that's the unfortunate thing about, you know, the bind nursing facilities are in terms of transferring people to the emergency department for behavioral health need, is that, as you know, often residents get there and are sometimes calmed down by the time they arrive, or they get there, they're still agitated, they're given some temporary medication with a plan for, you know, and with a request to follow through the next day and sent back to the facility, or they arrive at the emergency department. They certainly are in having a behavioral health emergency and may need to be hospitalized, and they sit in the ED for a long time, maybe several days, until a psychiatric admission is able to be arranged. At least in Oregon, we certainly are confronted with that frequently. Okay, next slide. So, as we talk about suicide and assessing that risk, I'd like to sort of keep in mind that suicide completions in nursing facilities are relatively rare, but people thinking about ending their lives is relatively common. And even compared to the general population, attempts are relatively common in nursing facilities as well. But most of those suicide attempts are passive. They have to do with residents who, are, refusing to get up out of bed, refusing basic care and hygiene, not eating, not taking medication, sort of that failure to thrive, or where, that may represent a long-term serious depression that may even predate their admission to a nursing facility. So, that's the most common way of people really shortening their lives in nursing facilities. The other thing, though, to keep in mind is that just as in the general population, older men are at the highest risk of suicide, as this is especially true when they have serious health problems and a recent loss. I think that's why men who have been admitted into a nursing facility in the past 7 months, are significantly at risk, because certainly, admission to a nursing facility represents loss, probably in a number of areas for male residents. Next slide. So let's think about Wayne. Was he at immediate risk of injury or death? At that point, he was stuck on the commode, couldn't get to the trapeze bar. So he's not able to walk. So no, he wasn't going to be able to act on his threat. However, next slide, the staff simply didn't know what else to do. So I would like to propose a system for empowering staff to really address urgent issues like that in a way where they feel like they have support, they have knowledge, and they have the means to make a informed decision on the next steps to take. Next slide. So it's possible for your facility to develop a crisis response policy. Such a policy really kind of boosts staff confidence in working with residents that are presenting with urgent behavioral health needs. If you're successful in diverting some people from going to the emergency department because of a psychiatric need, and that's going to improve your relationships with first responders and with the ED. And with such a policy, staff members that have good relationships with residents and are able to really use those skills really can get acknowledged and for their high level of interpersonal skills. So it really can help, I think, with staff retention. Go ahead, next slide. So there's 5 basic pieces of a behavioral health response policy. The first is to assess for risk of harm. We don't want people who are at immediate risk to themselves or others to stay within your facility. Those people need urgent help. But if that's not the case, for staff to step back and sort of make a plan, even in the midst of a crisis. And that plan will involve sort of involving the resident going forward, creating a plan for the next 24 to 72 hours, and then creating a longer term plan to help the resident through the urgent situation. Next slide. So first, assessing for risk of harm. And again, in Wayne's case, he had a plan, but he didn't have the means to carry out a plan. And for all residents, those are the things that you look at. Do they have a plan? What is your plan for it? I'm going to kill myself, and I'm going to do it right now. For first asking, how are you planning on doing that? And then assessing, do they have the means to carry out the plan? If at that point they're unable or unwilling to discuss their plan, or you can't get any further, then they have a plan and they have the means to carry out a plan, and they're unwilling to talk about alternatives like, can I remove the trapeze bar from your bed right now so that you can't use it to hurt yourself because I'm I really care about you, and I think we can work this out if we have some time. No way, you can't do that. I'm not going to let you do that. Or if they're engaging in a seriously dangerous activity, wielding a knife because there's unseen aliens, or, hallucinating and attempting to jump out a window, that sort of thing, then there's immediate risk of harm. We've assessed for it, call 911. And then communicate with the receiving emergency department about the reason for the transfer. So that's the first thing, is to assess for risk of harm. But if there isn't a risk for harm, if you've assessed that maybe there's a plan but not a means, or that this individual appears to be having more serious symptoms of their schizophrenia, does appear to be more delusional at this point, but isn't dangerous at this point, then go to the next slide. The first task is for the staff member to really sort of, okay, there's not an immediate risk for plan. I'm going to sort of get myself together and proceed to the next step. So that involves stepping back, stepping into the hallway. I'm sort of imagining this is most likely to be a CNA, could be a housekeeper, could be whoever happens to be in the room. So take a deep breath, clear that cortisol out of your brain, and gather whoever else is around. So the person that's around to talk to the staff member that's dealing with the immediate issue may be a charge nurse, it may be another CNA, it may be night shift, there's only the security personnel on, or whatever it is. The most important thing is to have somebody else to brainstorm with and to talk with. And staff member can describe the situation, sort of vent about what just happened, and then determine, what's the best way to proceed and who's the best person to work directly with a resident. Sometimes if a resident has just had a negative interaction with a staff member who was in the room, it might be better to go with a different staff member. Maybe Angie, who's working on the second floor tonight, is the one who has the best relationship with this resident. Well, can we pull her up and have her talk to the that resident? And while you're doing that, a staff member, if your area has a local 24-hour crisis response service, that would be the time to maybe call them and describe the situation and see if there's a mobile crisis response team they could come in, a way of sort of early on involving community resources to help this resident. Once sort of you have a plan, Frank's going to call the crisis line, and Lori's going to go in and talk with the resident. Then Lori goes in and talks with the resident. Next slide. So the most important thing about approaching the resident is to understand their point of view, to sit down and be at eye level with them as close as it's appropriate to maintain safety, and to establish eye contact. Have your body posture in a way that indicates that you really want to hear, and ask them what happened. Ask clarifying questions, validate their feelings. Boy, I can see that I can even tell by your body and by the tone of your voice that you're so frustrated and angry right now, or you are just really discouraged with the way that things are going. I can see how desperately unhappy you are. That those sort of validations, asking clarifying questions, what happened and then what happened, and not challenging their version of events, is a way to really get a sense of where the resident is at, as well as diffusing those most intense feelings, so that we can move forward into getting the support the resident needs over the long term. So ending the conversation with reassurance is really important. I'm really concerned. You sound so desperate for help, and I want to get you the help you need. Right now, I'm going to go and talk to, the nurse, and I also am going to try to find a way to get a phone in here, and let's see if we can call the crisis line. That sort of thing that can be helpful in giving the resident hope that they're being taken care of, and things are going to happen in a positive way for them. Okay, next slide. And once the resident is in a safe place, Then the charge nurse and other staff members, if they're available, will want to create a care plan for the next 24 to 72 hours. Normally, that's going to constitute some sort of observation and contact schedule. We're going to walk past the room and have eyes on the resident every 15 minutes, and we'll sit down and talk with the resident if they're awake every hour, whatever is really going to make sense and is possible to do for the staff. And then, assisting and contacting family or friends urgently may be very appropriate. If there's a guardian or a legally responsible party, advising them. Other things that staff may try is that if the resident's incident was triggered by some sort of oversight and care, even if the resident's response was extreme, somebody in authority could come in and apologize. PRN medications may want to be looked at this point. Call the doctor if that's indicated, of course, and then ensure that the appropriate department heads and other team members are notified about the incident in stand up the next morning or whatever your facility's protocol. Usual protocol is fit this policy into that in terms of how you convey what's happened in the shift before, huddle or whatever it is. Okay, next slide. So then after there's been an acute behavioral health incident, the next step is for the care planning team to schedule a post-crisis review, what happened, what went right, what went wrong, and to add to the care plan a problem specific to the incident, within about 72 hours. And you may write a policy where you want to give yourselves a week to do that, but have that occur fairly soon after the crisis. And the longer term care plan interventions may include obtaining a PASSAR level 2 or an annual resident review if this is a new symptom or a significant change. If this person has bipolar illness and now they're looking more manic and pacing, that definitely would be time for PASSAR level 2, also involving, psychiatry and that kind of thing, the local community mental health program as soon as possible. Scheduling appointments would be another thing to add. Staff may want to add more frequent contact with social services. Maybe part of your care plan is social services is now going to check in with them every other day. Activities is going to look at changing a plan, to interact with them in the hours when they seem to be having more difficulty. Getting healthcare checked. Involve telehealth counseling services. I'm optimistic that telehealth and telecounseling is going to be increasing. I just attended a webinar yesterday about how to really access telemedicine for counselors in SNFs. And so look for that to be increasing. And I have some resources on locating who's doing that now at the end of this training. And then specifically adding staff training for this resident and for supporting their needs is really advisable, even if it's as simple as, hey, here's what we're going to try during your shift stand-up at the beginning of each shift so that everybody sort of knows how to support this resident in the best way possible. Next slide. So, what happened with Wayne is that over the next few weeks, the facility, in fact, did do that longer-term behavioral health plan and did obtain a behavioral health assessment. They enrolled him in a local peer support program where he began to receive weekly calls from his peer support specialist. And they provided a staff training in sort of new strategies to help Wayne when he's angry, things to try, what works, what doesn't. And that's really, it's now a couple of years and he's remained stable with no further suicide threats since his trip to the ED. Next slide. So some things as you're thinking about how you're going to best intervene in residents with behavioral health needs. I'd encourage you to share your efforts with your local community mental health program. Say something to them like, hey, we're really going to start working with residents that are having more urgent symptoms, and we're wondering how you can work with us in that. Here's what we're doing. Do you see yourself helping with that? What services do you have? And make sure that you know your mental health crisis service phone number, what they do, what they don't do. Talk to them about whether or not they are able to come into your facility. Right now, with the COVID crisis, that might be a little more challenging, and brainstorm them even around that. Talk to your local police, fire departments, first responders about your plans. And even primary care docs might want to know for those residents who might have a potential, for issues. And even your aging and disabilities case managers, residents and families, sort of engage everyone in your staff, in your facility's intentional efforts to support residents who are having behavioral health difficulties in the facility, because that's what's best for them. Next slide, please.
Janet, I just want to give you a time check. We've got 4 minutes left.
Perfect. The other thing that would be very helpful to your staff, both in terms of their work in your facility, as well as the way in which they think about their own behavioral health needs, those of their family and their community, is to find ways to offer behavioral health training. Mental Health First Aid offers about an 8-hour training that they can do in one day or divided up over a couple of days. It tends to be about $25 per participant. And often Mental Health First Aid certified trainers will do a training in your facility. It covers a broad range of mental health topics. Question, Persuade, and Refer, QPR, is a 2-hour online training, and it's specifically on talking to someone about suicide and really gaining comfort in having that conversation. Next slide. There are a couple of national suicide and emergent health lines for older adults, the National Suicide Prevention Line, and then the Friendship Line is also an older adult sort of hotline offered out of San Francisco. Both those are nationally available. Oregon just instituted, Lines for Life added a loneliness line, senior loneliness line, and they expanded that statewide. So check with your state about whether or not there's any other sort of lines for people to connect with. Next slide. So first steps, and I've included a sample behavioral health response policy. Maybe you want to consider drafting one on your own, or holding a staff training, or maybe just going onto the QPR website, and there's one on healthcare settings. See if that might fit for you guys. Or just simply call and schedule a meeting with somebody at your local mental health program. See how you guys could collaborate on meeting your residents' needs, or look at telecounseling, what resources might be available in your area. Next slide. And so thank you very much for allowing me to talk with you today. So I think questions maybe, or?
Thank you, Janet. I appreciate all that you have shared with us today. I know that there are some questions coming into the chat right now. While we wait for chat to come in, make sure to include all panelists and attendees in your chat response. And I want to share with you an opportunity to join the Partnership to Reimagine Healthcare. And so we are embarking on a partnership to reimagine healthcare, working with providers across all care settings on issues like improving patient safety, increasing access to behavioral health, addressing opioid misuse, and improving care transitions by reducing admissions, readmissions, and emergency room visits. There's no cost to you. Joining is as easy as clicking on the link in the chat to sign up, or putting your name in chat, and one of our team leads will follow up with you. All right, so at this time, I'm going to take a look at the questions in chat. All right. What platforms are being utilized to secure telehealth?
You know, that varies from state to state. Yesterday during the webinar, they were talking about how many platforms there are. I know that my agency uses Mend, and I haven't even heard that mentioned in any of the things. So, but Google Meets, you know, I think that the important thing is for your facility to communicate to whoever you're considering with utilizing, about what platforms work best for you and trying to find one that you can really link up on.
Thanks, Janet. And I know we're at the half-hour point, and we'll take a few more questions for those of you who want to stay on. And for those who can't, this is being recorded, so you can follow up on any additional Q&A at your leisure. So thank you for joining us. If you have to drop off, we understand. So let's see, another question. Can you provide resources for the new skills to introduce to staff? Where can we turn to learn new ways to support our residents?
Well, that is a good question. You know, I would, in Oregon, we have an older adult behavioral health initiative, and so every county has an older adult behavioral health specialist that's able to offer trainings to facilities. So certainly in Oregon, turn to your older adult behavioral health specialist for trainings. And in Oregon, you can email me if you don't have that list. In other states, your first stop might be to your local community mental health program. Let them know that you really would like some training in supporting the behavioral health needs of your residents. And you can start with saying that you would appreciate just some basic skills on how to talk to a resident that is really upset or depressed. What kinds of things should you say to them? How can you be supportive? And so be specific in kind of what you'd like your training to look like as you're entering into this endeavor.
Thanks, Janet. Another question, is anyone talking with Medicare about covering counseling provided by social workers as a separate service for SNF residents? Currently, this is considered a bundled service and not separately billable.
That is also a good question. So I think that there's a lot of conversations going on at a much higher above my pay grade. Does one of the other panelists have an answer to that? Yeah. Yeah, the Medicare billing for behavioral health services is problematic. So I'm not sure.
I do know that telehealth is separate, so there might be an opportunity there. We were just informed that if you are the hosting site for telehealth, that you can bill about $25 or so as being that host site. So there are some opportunities there.
And Nirmala Dar, our state behavioral health coordinator, just mentioned that you know, licensed social workers can bill Medicare for SNF residents. I'm not sure, Nirmala, whether or not that's possible within their 100 days of their skilled Medicare stay, or if that is after that's expired, because what I'm hearing is it's a bundled service during that skilled stay, but I could be wrong about that.
There's certainly lots of complexities to this topic.
Yes.
All right, at this time, I think we've gotten to most of the questions. If you have a burning question, please email us and we will get that to Janet. And otherwise, thank you so much for spending some time with us today. We know that in these challenging times that your time is precious, and we hope that you were able to walk away with one nugget, one action item that you can take on this next week and implement in your community. So thank you for your time. Thank you, Janet, and everyone have a good weekend. Bye-bye.